Now, you might think, well, why would that be such a bad thing? If the immune system's more active, then doesn't that mean that, well, we'd be more resistant against infections, or maybe we would heal faster? But the problem comes in with how the immune system responds, how the immune system handles healing and defense. And so this goes back to what I had just mentioned in terms of the way the immune system responds. You can see on the slide that there are a number of these so-called mediators, and what's uniform about these mediators is that in the right circumstances they are, and generally when released by the immune system, they're inherently damaging and harmful to cells or other organisms. But there's nothing specific about this, so they're also harmful to us. And those same mediators that are so effective at damaging a bacteria also can damage our own bodies, whether it's in the joints or the blood vessels. And so that's the problem with chronic inflammation. Now you have this damaging process ongoing. I would use the analogy, it would be like if you had a security force at a facility, and they were keeping an eye out, and anytime somebody tried to break in, they would jump up with their weapons, and they might start shooting at the invaders and chase them off. But just imagine if they were just overly, hyperly alert, and now your security force is active all the time, and they're just shooting at every little sound and everything that moves. And when you get back the next day to go to work, and your whole factory's been all shot up because they were just using an indiscriminate response and constantly active. And that's the immune system when it's chronically active. It's really just tearing up our place of business. So chronic inflammation has been implicated as a causative factor in a wide range of medical problems or so-called chronic diseases. And so this is a list that is by no means comprehensive, but chronic inflammation is clearly the main problem with so-called autoimmune diseases. That term autoimmune means that our own body's immune system is attacking itself. And so examples would be rheumatoid arthritis, lupus, inflammatory bowel disease, psoriasis, and there's a wide range of these problems. But even things like chronic lung disease, like bronchitis or emphysema, involve ongoing inflammation. Gum disease or periodontitis, skin ulcers that don't heal. Even things like dementia or kidney disease and cancer, there's an inflammatory component. And in fact, just in general with aging and as we become more frail later in life, markers of inflammation are elevated. At this point, I'm going to talk about two other inflammatory diseases which are extremely common and important in my practice as a cardiologist. So the traditional view of heart disease, and specifically coronary artery disease, is that plaques would build up in the arteries because there was too much fat and cholesterol in the blood, and it was really no different than if you dumped oil down your pipes, that eventually those pipes would become clogged up and you couldn't get anything through them. And so the idea was that what we're dealing with is just a so-called lipid or cholesterol storage disease. You're having these substances stuck in the wrong place just because there's too much of them. That view has been changing over the past really 3 decades, and all the lines of evidence point to so-called atherosclerosis, this plaque buildup in the arteries, as being more complicated and for chronic inflammation having an integral role in the process. And so what we've learned actually happens is that while it is true that lipids do end up inside the walls of the arteries, it's the response to the lipids being there that results in the formation of plaque and the progression and worsening of plaque. And so what happens is that for some reason, the walls of the arteries where the cholesterol is start releasing these substances or mediators that are attractive to the innate immune system. And white blood cells will start crossing the wall of the artery and entering the space where the cholesterol is. And there's then a reaction where these white blood cells will then engulf the cholesterol that's there. And over time, they start to expand and even divide within the arterial wall, and this process becomes self-perpetuating. And so you have more and more of these cells, which predominantly are, again, these so-called macrophages that take up the cholesterol, and eventually the effects within the cell is that these cells will then die within the plaque, and then you have dead tissue. And recall, what does dead tissue do with inflammation? Well, it's another way of triggering more inflammation. And so you have this process which perpetuates and amplifies, and all of this really is driven not just by the presence of the cholesterol, but again, it's the way the immune system responds to it. So one of the questions is, so why is it that the immune system is attracted to the walls, and what's going on here? And what's very interesting is that it may not just be so even with the idea that inflammation is involved with atherosclerosis, still the widespread idea is that there's something about the cholesterol being there that starts the inflammation going in the first place, and that's not necessarily, I wouldn't necessarily disagree with that, but there's a relatively newer idea that it's not just cholesterol being in the arteries that's starting the process, because of course always in these situations the question is, well, what's coming first? What's the original insult that starts the ball rolling? And this newer idea is that there's essentially, it's been termed an echo effect, where you have inflammation somewhere else that's then triggering inflammatory mediators that are now circulating in the bloodstream, and then they can act remotely and start inflammation happening in other places. So for example, in experiments, and where this idea even started from quite some time ago, they would use something called lipopolysaccharide, which comes from bacteria and can often get in the bloodstream when there's some sort of infection somewhere. And then that lipopolysaccharide would then increase the inflammation happening in the walls of the arteries. It's like there's a cycle where, so for instance, in this example, you see somebody has a heart attack. Well, that was caused by plaque, and the plaque causing a blockage that caused a heart attack. But then the heart attack causes other things. So the heart attack stimulates activation in the bone marrow. It causes stress and pain and anxiety, which then stimulates adrenaline, which then stimulates the white blood cells in the bone marrow further. And now the active inflammation, because of the effects of the heart attack, it starts affecting the walls of the artery. And guess what you end up with then? More plaque, and more unstable plaque, which then increases the risk for having another heart attack. So these things build upon themselves, and it's not just a separate process just in the arteries of the heart. So how do we know that, inflammation really is causative? And we have there's a lot of kind of basic science knowledge in terms of seeing what's in the arteries and looking locally, but how do we know that this isn't just an effect rather than a cause? One way we know this is that we have now evidence that certain medications that reduce inflammation can actually reduce the risk for heart disease. So I'll talk in a few moments a little bit more about something called C-reactive protein, but briefly, C-reactive protein is a protein that circulates in the blood. Most of it's made in the liver, and it's what's called an acute phase reaction. So anytime there's inflammation, the C-reactive protein can go up, and sometimes with severe acute inflammation, it can go up very, very high. But even when elevated at lower levels, it's been attributed with increased risk for heart disease. So C-reactive protein is decreased by statin medications. So these medicines are thought of as cholesterol-lowering medications, but they have other effects, and one of them is that they do lower C-reactive protein. And so what you see on the left panel here is that this is just from one example of a study looking at statins in patients with heart disease to reduce the risk of future cardiovascular events. And so the baseline, or the placebo group, this is the top line, which had the highest event rates. And then there's actually, I don't know if you can see that well, but there's actually two lines that are almost overlapping in the middle. And these two lines represent patients who either had a reduction in their LDL cholesterol or had a reduction in their CRP, but not both to the same degree. And either way, there was a reduced risk for future heart attacks. But then you see the lowest line, which corresponds to the lowest rate of heart attacks or future events. And these were patients who had both reduction in the CRP and in their cholesterol. So there is a unique effect of lowering CRP that has benefit, or lowering inflammation, that's separate from the cholesterol-lowering effect of the medications. And then more recently, there was a large trial done, over 10,000 patients, of a medication called canakinumab, which is a medicine that attacks another arm of the immune system, and actually does reduce CRP, but reduces something called interleukin-1 beta as well. And what they found is that when they used this anti-inflammatory medication in addition to statins, so it was used in addition to standard care for patients with heart disease, there was a further 15% reduction in the rates of heart disease that had nothing to do with lowering cholesterol. So these lines of evidence showing that reducing inflammation with medication does support which having that subsequently reduced risk for heart attacks shows that the inflammation just isn't something that's happening because of the heart disease. It's actually a cause. One question that I sometimes get, and I think is a very important question, is if inflammation is controlled, does the cholesterol even matter at all? And I would like to answer that question right now, but unfortunately I can't, because we don't really know the answer. On the one hand, based on the model that I just described to you, one would think that if you could prevent the activation of the immune system at all, then maybe the cholesterol would just get into the walls of the artery and go out of the walls of the artery and not really cause any problems or issues. But then again, maybe it would. And there is evidence pointing to both inflammation and cholesterol being a problem. Interestingly, and what I think particularly strong supporters of the cholesterol side of the argument would point to is that there's a newer class of medications for cholesterol lowering that were developed by observing that there is a population of people who have very, very low LDL cholesterol based on genetic differences from birth. And this particular group of people have extremely low rates of heart disease. And so you could look at that and say, well, if you have extremely low cholesterol for your whole life and you don't get heart disease, then that shows that the cholesterol is the main issue. But then again, you could just as easily look at that line of reasoning and say, well, how are these people not exposed to inflammation? So maybe the cholesterol being there is just a what you might term a permissive factor. So if there's no cholesterol, the inflammation isn't activated, but it doesn't mean that if the cholesterol was there, but you could somehow not have the inflammation, that maybe there wouldn't be an issue. The real challenging thing is, in our modern day and age in society, how do you not have the inflammation? Because it seems to be so ubiquitous. And even when we adopt real food, low carbohydrate lifestyles later in life, and even if that were to reduce any measurable inflammation, we don't really know what's going on at the level of the arteries, and if that truly would eliminate any risk. So again, this is going to be an ongoing question, and I wouldn't hold my breath that it gets answered anytime soon. So shifting gears a little bit, let's talk about metabolic syndrome. So metabolic syndrome consists of a number of different, I like to think of them as risk factors for heart disease, but more broadly just metabolic derangements in the body that while seemingly might be unrelated, tend to cluster together things like fatty liver disease or insulin resistance and blood sugar abnormalities, and certainly obesity or fat gain. So all of these different conditions are associated with chronic inflammation. In the case of obesity, it's been described from, even I think going back over 100 years ago, that macrophages are found within the fat tissue itself. And these macrophages, but also the fat cells, have the capacity to elicit inflammatory mediators. And just as occurs in the arteries of somebody who's developing heart disease, this process is self-perpetuating and amplifies. Additionally, a number of these inflammatory mediators are directly involved in the signaling pathways that appear to lead to insulin resistance. Insulin resistance is one of the main underlying problems that contributes to all aspects of metabolic syndrome. And what happens is the organs of the body can no longer properly respond to the signaling involved that should be telling us that there's plenty of energy and we don't need more, and this signaling that then leads to energy storage starts to go awry. So the inflammatory mediators released by cells from the immune system in chronic inflammation actually act within the cells to directly manipulate the insulin signaling and the targets of the insulin signaling, and so these things are not separate at all. One of the linking factors between metabolic syndrome and obesity as a chronic inflammatory disease with the effects of heart disease, beyond the fact that these things are risk factors for heart disease, and really possibly answering the question of why are they a risk factor for heart disease, is that a lot of these mediators are actually lipids or fat in the blood. And one potential connection between the inflammation in all of these tissues is that what we know is, and thanks to the work of Jeff Volek and Steve Finney, researchers in the low-carb space, is that contrary to, I think, what many would suspect, in people who are eating high-fat diets, levels of fat in the blood are actually very low. On the other hand, people who are eating low-fat diets that are high in carbohydrate actually have very high levels of fat measurable in the blood. And these free fatty acids have been linked to causing chronic inflammation and causing insulin resistance. And it may be these free fatty acids and other lipid mediators that are the inciting, or that echo factor that is contributing to inflammation in the arteries that carry blood to the heart. So given that, that chronic inflammation is so important to all of us, given the links to these chronic diseases that so many of us are suffering with, how do we measure it? There are So there are a few different blood tests that can be done. The most common and best validated is a test called C-reactive protein. So again, the C-reactive protein is mostly made in the liver, and it's increased in any form of inflammation, including chronic inflammation. The standard test for CRP actually is not sensitive enough to detect low levels, but can be elevated in things like bad infections or severe injury or very uncontrolled autoimmune diseases. But there's another CRP test, which is called a high sensitivity CRP, or sometimes the labs will call it a cardio CRP. And that will measure very low level elevations in the C-reactive protein. The reason it's called cardio CRP by some labs is because the CRP test has been so tightly linked to heart disease risk. And so you can see, even when the CRP concentration is rising to a level of 1 milligram per liter or above, levels that would be undetectable by the regular test, you see a significant increase in risk in heart disease. And the panel on the right hand of this figure, I think, is very interesting, because if you compare the proportional increase in risk associated with increased CRP to a number of more traditional heart disease risk factors like blood pressure and cholesterol, the degree of increased risk is very similar. So that's the number there, the 1.37, et cetera, is you could take that's the percentage increased risk. So with the CRP, a 37% increased risk for CRP elevation versus actually total cholesterol was lower in this particular analysis. So CRP is probably the easiest, cheapest, and best way to measure. Another test is one called fibrinogen, which also can be measured as a lab test and is associated with cardiovascular risk and directly involved in blood clotting. Another test is one called myeloperoxidase. The myeloperoxidase, you can see that when it's elevated, even in cases where the cholesterol numbers or even the CRP are normal, the myeloperoxidase provides further information as to increased risk. So then the most important question is, can the inflammation be reduced? Because why measure it if we can't do anything about it? And the answer to that, you won't be surprised to hear, is yes, thank goodness. But it's probably not going to be with medication. So recall I described that study where they used this antibody that resulted in a 15% reduction in heart disease risk in patients who already were on the very best medications otherwise available. But guess what else it did? It killed them. So it caused increased mortality from infections. And so at this point, the medication is certainly not ready for prime time. This is a very tightly regulated process in the body. It's something that, again, it's not good, it's not bad, it depends on the situation. And so if we just treat it with one component and we're not able to properly regulate it, then we're likely going to have unintended consequences. And unfortunately, that's likely going to be the case with any medication, in my opinion, because it's such a complex process. Remember, I don't understand it. So what about weight loss? Well, weight loss is an effective treatment for inflammation. So many studies have shown this. Generally speaking, the weight loss needs to be pretty significant, over 10% of body weight. Bariatric surgery has been shown to be an effective way of reducing some aspects of inflammation. And in most of the studies where this has been looked at, these weren't studies of ketogenic diets, this was just losing weight. Now my guess would be probably people who are successfully having 10% weight loss or more are probably taking in less carbs overall, but generally speaking, weight loss as a rule broadly, it helps. How about exercise? I always tell my patients, exercise is not a tool for weight loss. It doesn't mean you shouldn't exercise, so bear that in mind when I say exercise is not necessarily a tool for reducing inflammation. It doesn't mean it's a bad idea. This is something, this picture is of something that I didn't know existed until I was preparing for this talk. This is called a Sisyphus machine. There you get to exercise on the treadmill and push the boulder all at the same time. And so sometimes I think that exercise can be a bit of a Sisyphus machine for those of us who pursue it with hopes of results such as weight loss or reduced inflammation. It just doesn't do those things necessarily. So studies of exercise for reducing inflammation, the best I could tell, seems like if it's combined with interventions for weight loss or more broad lifestyle interventions, works, but with exercise, when you isolate it by itself, maybe not so much. It's a mixed picture. So how about the ketogenic diet? Is a ketogenic diet more effective for reducing inflammation? And the answer here, I think, is yes, although there's room for a lot more research. So one idea is that it may be one of the ketones, the beta-hydroxybutyrate. It may be that this ketone has particular positive effects at reducing the inflammation. In terms of changing this ROS, is reactive oxygen species. This is the way that the immune system will use oxygen to actually create damaging chemicals to kill infections and clear dead tissue. It seems that with a non-ketogenic diet, these things may get worse, whereas on a ketogenic diet, the beta-hydroxybutyrate may be particularly effective at reducing the reactive oxygen species. Additionally, there's a lot of exciting research that ketones directly affect something called the inflammasome. So many cells, but particularly immune cells and macrophages, the immune response happens because of something within the cell called an inflammasome, which then leads to the inflammatory effects, and it seems like the beta-hydroxybutyrate will downregulate this. In any case, whatever the reasons for the benefit with the ketogenic diet, it does seem effective. So this is an example from a 12-week study of low-fat versus a low-carb diet, and you can see the high-fat low-carb, that's the HFLC on the right, has a significant reduction in CRP, whereas the CRP didn't change a whole lot on the low-fat diet. And there are some other studies showing similar effects and looking at other inflammatory mediators. I want to show you a figure here. This is from a study done by the Virta Health Group in diabetics, and this is extremely exciting because this is a 2-year result, and it shows that this lowering of CRP, again, is more effective than the usual care, and it's a sustained result. We measure CRP tests in most of our patients, and while I don't do research and I haven't looked at it in a systematic way, having taken care of thousands of patients and measured the CRP, what I can tell you is a lot of times it doesn't change a whole lot early on, but it continues to decrease over the course of years. You know, I think, as Eric said, Dr. Atkins said, I sort of feel like I don't need research because I see this happening and it's real. And lastly, I'm going to end by talking about exogenous ketones because there's a lot of, I think, enthusiasm and interest in actually taking ketones as a supplement, with the idea being that, well, if ketones are good, can we augment them even without a diet to reduce inflammation? And again, this speaks to the effect that the beta-hydroxybutyrate seems to be having on this so-called inflammasome. We don't really know at this point. It appears that there's some pretty good evidence in animal models, but so far we don't have a lot of evidence in humans. And I'm a little bit skeptical because, again, it goes back to the idea that chronic inflammation and the whole inflammatory and immune system is such a complex, tightly regulated system that having a single chemical or supplement or medication to intervene at one location, I think there's a high risk that there may be unintended consequences. And there was a recent study in human beings using exogenous ketones, and surprisingly, when they measured, on the left you'll see these some inflammatory mediators. They actually saw an increase in the inflammatory mediators in human beings. So at this point, I think that your best bet is a well-formulated, real food-based, low-carbohydrate lifestyle. Essentially eat the way our bodies are intended to be fed, and then let your body worry about regulating the immune system. So in conclusion, chronic activation of the immune system has significant negative effects on human health. Both atherosclerosis, heart disease, as well as obesity and metabolic syndrome can be thought of as inflammatory diseases. The inflammation may be the major link between metabolic syndrome and heart disease. And inflammation can be quantified and tracked with blood tests. And if you were going to track it at all, I would recommend the CRP as being probably the starting point and most useful. And we can reduce inflammation through lifestyle change, and albeit limited evidence thus far, it seems that a ketogenic lifestyle is your best bet. Thank you very much.